as Lesego introduced me, I'm Jocelyn Moyes. I'm part of a team at the Center for Respiratory Diseases and Meningitis at NICD. And I'm really excited to share some of the epidemiology of respiratory syncytial virus, or perhaps what is less of a mouthful, RSV, in South Africa. And I'm going to take you through some of the work that we've been doing on RSV, and you can see that we've got quite long-term surveillance, and so we've got a really good base of data on RSV, the epidemiology of RSV, and then I'm going to move to show you some the results of some modeling that predicts what we might see in the hospitals in this present RSV season. So I think that lower respiratory tract infection for clinicians is really you guys are well in touch with what's going on, but it is the commonest cause of death in children in South Africa. And 20% of the deaths in under ones are from a lower respiratory tract infection. And the most common cause of lower respiratory tract infection in children in South Africa is RSV. And globally, estimates that are put together through contributions from global data suggest that there may be as many as 3 million RSV-associated lower respiratory tract infection hospitalizations. So you're starting to see that this is a massive burden of disease, and up to 100 or 120,000 deaths occur annually across the globe. The majority of these occur in low and middle income countries. And I'm sure many of you are aware that RSV is very treatable, but we know in low and middle income countries, access to care and quality of care are not always in place. So RSV is considered a seasonal disease. In South Africa, we do see year-round circulation, but we have a definite, or certainly up until 2020, we had a very definite late summer, early winter peak, and which we have defined as our RSV season. So I'm not going to take too much time on the clinical, but just to say that RSV can be a severe disease in young infants, and it's really unclear whether this is because of an immature respiratory system or whether older children, after having had multiple RSV infections, then have some sort of protective immunity. So I think there's still quite a lot of work to be done on the pathophysiology of RSV. So why is this interesting, or why is NICD interested? Why could you possibly be interested in RSV? And I think what's really important is there's some very interesting technologies in the pipeline for RSV prevention. And so there are the options really that are being worked on are maternal vaccines, infant vaccines, and then some longer acting monoclonal antibodies. So presently in the private sector, you should be able to access palivizumab, which is PZV, which is a monoclonal antibody, extremely expensive, very short acting, has to be given in multiple doses. So it's not really ideal, certainly for introduction into a public healthcare system. The reason why there's a focus on maternal vaccines is because we really want to protect the very young child, and I'll show you why as we go through the epidemiology. So maternal vaccines are a big focus. Infant vaccines are not as in focus, but there is certainly some interest in developing infant vaccines that could boost the maternal vaccine. So once the maternal antibodies start to wane, we could then introduce an infant vaccine that would get children just a little bit older before they have their first RSV infection. And so this little snapshot of what is available, or what is in the pipeline, is available from the PATH website, and it's updated on a monthly basis. But you can see that there are monoclonal antibodies that are already market approved in the States and so on, and there's some coming up the pipeline which are in phase 3 trials. So then there are just a number of different maternal vaccines that are also very close to being approved and released on the market. So we as NICD, and our mandate is public health and surveillance. So we realized that it would be really important to have a body of data to present to policymakers to try and motivate for introduction of one or more of these technologies for RSV. So what have we been doing? In 2009, we started a countrywide surveillance system for influenza-like illness. So that's mild outpatient respiratory illness, and then severe respiratory illness, which is hospital-based. So we have sites in Mpumalanga. So Mapulaneng and Matikwana hospitals joined us right in the beginning, and then Tinswala we added in 2020. We have an outpatient clinic at outpatient surveillance point at the Asian Court Clinic, and then we're at Edendale Hospital here in Pietermaritzburg, and at the clinic here, Rahima Musa Mother and Child Hospital in Joburg, Klerksdorp Sipong Hospital in the Northwest Province here in Klerksdorp, as well as a clinic here. And then in the Western Cape, we have the Red Cross Children's Hospital, Mitchell's Plain Hospital, and the East Ridge and Mitchell Plains Clinic. So it's quite a wide, it's quite a wide network. We've covered most of the geographic zones, so the sort of subtropical areas of Lowveld and Mpumalanga and KwaZulu-Natal, and then the temperate highlands of the inner part of the country. And then, of course, Cape Town, as we know, it thinks it has its own government, but it definitely has its own climate zone. So what have we seen and what have we described? So over the, from 2010 through until 2019, these are our full years of surveillance, you will see that that every year we see this peak. So these are the weeks of the year, right through 1 through to 52 would be there. And this is the number of positive samples, these bars, and this is a detection rate. So the number of these samples that were positive, or the percentage of these samples that were positive. So you can see in the under ones, there's a very substantial peak, usually from week 7 or 8 of the year, which is around February, and trickling down through and dropping off sort of May, June, July. In children age 1 to 4, you see the peak is not nearly as high. You'll note that the axes here are slightly different. The peak is not as high, but there's still a definite peak in those months. And then RSV detected all the way through the rest of the year. So what are the risk factors for RSV in our setting? It's very young children less than 2 months of age. You can see the adjusted odds ratio in these children. They have, there's 50. The odds of them getting RSV is 54 times children in other age groups. So that's a very strong indicator, and that will come out in all our data. But you see that the odds are still high all the way through the first year of life, and then dropping off some. Malnutrition is a risk factor, as is prematurity and HIV infection. So I think, probably not very different to other respiratory illnesses, but, nice to see it specifically for RSV. So what is the burden? And by burden, we mean the number of cases all per 100,000 of the population. And we can see that the burden of RSV is high. I mean, this is over 14,000 cases per 100,000 population a year. Sorry, yeah, that's right. And you can see that the highest burden is in the first and second month of life, and it drops off substantially. By the time you get to 5 years, the burden is very low. So the green line is the total. The red is those that are not hospitalized, so those that would stay at home but still have severe illness, and then those hospitalized. So you can also see there's a burden of disease that doesn't reach our hospitals. And so these children are sick at home. All right, so that was for severe illness. If we have a look at the mild illness, you can see that the burden is a little later the big burden is a little later in life for children with mild illness. And then it kind of carries on, mild illness, all the way through until 24 months of age. Okay, so this is the kind of illness that would take the child to an outpatient clinic, be seen by somebody there, and sent home. So it's, they're not particularly ill, but it's a burden of disease. And this burden of disease, it may not be costing the hospital system very much, but it's costing families and it's costing the economy, because sick children are keeping parents, at home and stopping economic activities. What's also very interesting to see is that the non-medically attended, so those children with RSV-associated mild illness, many of them don't seek care. And so the medically attended is, cases in the blue line, much lower. So these children are sick, they're at home, but remember the burden of the mom staying at home to look after the sick child and not being able to be economically active, and so on. So we also conducted, as part of our surveillance, we also conducted a costing study. So we nested this within our surveillance activities, and we gathered costs of healthcare from the hospitals, and we gathered information on the cost for parents of having a child admitted. So the actual costs that it cost them, so what it costs they took out of their pocket for transport and so on. And then we also looked at the indirect costs, so what it costs the parent to have a child in hospital, losing work time, the family loss of family income, and so on. So, and what is interesting is that there is the cost to the healthcare system is in the very young child, and that fits with the burden because that's where most of the cases of severe illness are. And then, but there's this cost to the healthcare system and to families and the community in these older children. And this is that cost of what I showed you before, this mild illness that's taking them to a clinic or to a pharmacist or somewhere, but it's not actually getting them admitted to hospital. So a substantial cost, here is the total cost of medically and non-medically attended mild and severe illness, quite substantial costs to the government and to communities or to a healthcare system, not insubstantial. Okay, so what happens? So that's all very nice. We had all these nice data. We kind of thought we knew where we were going with RSV. You know, it was very predictable. We could talk about introducing seasonal monoclonal antibodies because we knew exactly when the season was going to happen. And, you know, we could, it's all very nice. Tell the government how much it's costing. But then what's happened with the pandemic. Okay, so, excuse me, when the pandemic started, we introduced these non-pharmaceutical interventions to stop COVID. And so really what happened was we also prevented a large number of other respiratory illnesses, flu, RSV, you know, well, flu almost disappeared. RSV really dropped down dramatically. But then there was a question of, well, what happens when we stop these non-pharmaceutical interventions? So that's the masks and the distancing, closing of schools, all those kind of interventions that, you know, that we put in place. What would happen? And there was this concern about, you know, if children are not getting these repeated RSV infections when they're young, you know, what will happen to them now? Will they become, you know, will we see it in older children? Will it be more severe in older children? And so then, and you know, lots of information started coming out, like no RSV seasons, low RSV seasons in a number of countries. And so obviously, as part of our work, and when we went battling COVID, we started to have a look a little bit at what was going on with RSV and flu. Okay, so here, this graph shows us what I've been showing you all along, that this is, these are our RSV seasons prior to COVID, the beginning of, all around the beginning of the year, showing you and the blue line showing you our average season in the years 2015 to 2019. What happened in 2020? We saw this much lower peak. So this is when we introduced, the lockdown was about here. So there was already some RSV circulating, but it never reached anywhere near the average RSV circulation. And it sort of grumbled along. But then here in 2020, when we started to open up a little bit and there was a little bit of return to school, we saw this RSV season completely out of our normal sync. And then in 2021, it sort of looked like it might get back to normal, but peak still not quite as high and sort of grumbling along towards the end of the year. Okay, when we plot these together with flu, you can see quite nicely how they all fit together. So ILI is influenza-like illness. That is the mild illness occurring that we are picking up at outpatient clinics, and severe acute respiratory illness is what would be in the what we would be picking up in our hospital-based surveillance. So you can see 2015 through to 2019, RSV usually precedes flu. So just as RSV is starting to drop off, the flu season will start. And then some years it's a bit more of an overlap, and other years it's much clearer definition. So when we got to 2020, we had a little bit of sporadic flu early in the year, mostly in the Western Cape, a little bit out of sync with what we normally see. And then obviously we had this peak of COVID. And then you can see almost as COVID drops down, a little bit of RSV popping its head out. And so it seemed that the RSV season was interchanging with the COVID circulation. And pretty much the same in severe illness. Just we didn't get a flu season at all in 2020 or in 2021. You can see there's no flu. The end of 2021, you can see a small little bump of flu in our mild illness there. So flu disappeared, but RSV kept circulating just out of sync, out of season, and a little bit confusing. All right, so we set together to do a modeling exercise with some international modelers to see if we could work out what was going on. So one of the things that was interesting with this sort of modeling and looking at this data was that the proportion of annual hospitalizations in this young age group was fairly consistent. So you can see that in the 2015 to 2019, 2020 and 2021, no, really not much difference. But what's interesting here is that we see that a drop off in this 3 to 5 month age group in 2021 and an increase in this age group in 2021. So it's almost like the age group of the RSV cases is shifting to the older child. And these are perhaps children that were not exposed to RSV early in their early part of their lives in 2020. Okay, so this suggests to us that the severity of illness later in life is you are protected from severity of illness having had it as a young child. And these are the group of children that probably missed out on that, but were protected by the non-pharmaceutical interventions. Sorry, got myself a bit confused with the slides there. Okay, so what do we predict for this year? We're predicting that there may be as much as a 32% increase in the number of monthly hospitalizations compared to the pre-pandemic years 25 to 2019. Now, those of you who are in the hospitals will know that the bronchiolitis season or the season of RSV is already quite intense. And as you can see from our previous data, up to 65% of children admitted during the RSV season have RSV as the cause of their lower respiratory tract infection. So a 30% increase on that is quite substantial. We predict that these children will be older. And so those are the things to look out for. Whereas you'd expect your bronchiolitis usually to be in younger children, you can expect it now to see it in the older age groups. Okay, so where are the conclusions and where is this going? So I think that establishing surveillance for RSV in South Africa has been really valuable as a group of data or as a collection of data that has really helped us to establish the risk factors, the burden, the seasonality of RSV, which will assist when interventions come along. We will be able to say to policymakers, you have this many cases, it costs you this much. This is your season. If you want to give monoclonal antibodies prior to the season, this is the time to give them. If you want to do maternal vaccine programs and you can't afford to give them year round, this is the season. What about vaccinating pregnant mothers between November and February to protect those infants born between February and May? And so I think that, I think we're one of the few countries in the world actually that have this body of data together. And I think it's going to be very useful as soon as vaccines and monoclonal antibodies become available. I also like to thank any of you who are working in any of those surveillance hospitals. You may not know that you've contributed, but you have by being there and assisting our surveillance officers to do their work. So it's really been useful. And then I think what we've all been talking about for some time is that these non-pharmaceutical interventions have, they slowed the spread of SARS-CoV-2, but they've also slowed the spread of other respiratory pathogens. And I think that although this is, in a way we were saying, well, could we eradicate flu if we just kept wearing masks forever? I mean, obviously we know that's not practical, but as you saw, flu completely disappeared. So, is that an elimination strategy or not? I'm not suggesting it is, I'm just posing the question. These are the things we've been thinking a little bit about, but, the other side of that is we protected children from RSV in those very vulnerable months of life, but have we now just created a problem in the slightly older infant and those children under the age of 2? So there's always swings and balances. So just to say that we're predicting a 30% increase in the peak of number of monthly hospitalizations in infants less than 2. And we may see the 6 to 23 month olds being a larger proportion of severe disease. We have certainly had discussions with Rahima Musa, during our surveillance meetings, and their feeling is that it is a much bigger peak of hospitalizations starting a few weeks ago, and that children were a little bit older. So it will be really interesting to hear your experiences and clinical experiences so far in the hospitals. Is this what you're seeing? And then just to let you know that it really would be worth your while getting, anticipating this and doing whatever preparation that you are able to do to prepare your hospitals, clinicians, nurses, people in clinics that, that RSV is coming our way. Okay, that's the end of my presentation. Lesego, I don't know whether you want to take your questions at the very end.
No, yeah, firstly, just to thank you very much, Dr. Moyes, for a very insightful presentation. I think before I ask Dr. Shibabo to share on the clinical side, just maybe some few questions and then we see how far we go. There was a question to say on your list of your surveillance sites, there's an audience here from Limpopo.
Limpopo, I see, yeah.
Yeah, they wanted to know why is or not that Limpopo is not included on the list. I don't know if there's a specific
Well, it's not really a specific answer. I actually think Tswalo might be almost in Mpumalanga. I mean, in Limpopo, but not quite. I think it's on the border, but that's not it. That's just we initially chose sites in some of the areas. We chose sites because we were able to get population denominators to do the burden studies. So we needed hospitals where there was a defined catchment area and where population numbers were available for those population areas. One of the reasons why we chose the 3 sites in Mpumalanga is because the demographic surveillance site is there and they have very strong data on population and community, which enables us then to do additional studies. So some were chosen like that. Some were chosen purely by having an enthusiastic clinician at the hospital who was prepared to support us putting our surveillance officers, nurses in the hospital. So it really, it really wasn't, there's no sort of exclusion or inclusion in some cases. So if someone wants to put their hand up in Limpopo, please do. We'd be very happy to do a site visit, have a look at what you, what the hospital looks like, what the clinic looks like, and we can certainly discuss it. Ultimately, it comes down to funding, but we're not exclusive. How's about that?
That's great. That's great. I'm not sure. Aluwani, do you have a question or is your hand up? So I've given you some rights to ask your question. You may unmute. Otherwise, if it's a false hand, you may lower your hand, but you may ask your question. Aluwani. Aluwani, are you able to unmute? Otherwise, I will continue to my next question. All right. I don't think, okay, let's try one more hand. Otherwise, we will move on to some of the questions I have. Kutele, you may want to unmute your mic. You have talking rights. Kutele. Kutele, you may unmute. All right. No. It's okay. There was also a question, Dr. Moyes, to say, let me see who made that particular question. I think it's Thomas Mailula. He says that he noticed that there was some suppression of RSV after lockdown relaxation restrictions in 2021. Do you still attribute that to non-pharmaceutical interventions for COVID, or there's other things we need to consider?
Sorry, I'm just trying to work out the timelines in 2021 in my head, so I can remember where our peak was.
Yeah.
Look, I think masks do definitely play a role, because obviously they played a role in in preventing in the transmission of COVID, and I think there's quite a lot of evidence to suggest that universal wearing of masks does prevent transmission of respiratory illness. Obviously not 100% and not perfect. So, we had a peak after the relaxation of lockdown restrictions. And I think that that's probably when children went back to school. But you know what, kids are like with masks, they don't wear them all the time and they don't wear them properly. So, maybe it's suppressed it, but didn't have as dramatic effect as when we also put people in their homes and separated them and added that to it. So yes, I do think that that's why RSV came back, is that there was a lot more mixing. Children went back into daycare and into their schools.
Now, this one is from me, and it's building probably on the same discussion. I just wanted to understand whether viruses can interact in the environment and maybe leading to some mutations or genetic changes that would make one virus less virulent. Because I saw in certain instances you had less flu, but you still had RSV. So the non-pharmaceutical interventions cannot be the only reason for that. So I see you had important changes on the RSV side, maybe becoming more infectious for a different population of children, but you had fewer cases of flu. So I want to understand how common is the interaction of viruses such that we start to see genetic changes which lead to either a more fit or a less fit virus in this instance.
Okay, so that's a whole lot of questions in one.
Yeah,
Simply,
no,
that's okay. I think that viral interactions are really interesting. Whether those interactions occur in the environment or in the host, that's very interesting on a virological level and on a clinical level. I think there's still a sparsity of data as to how viruses interact in both situations, in the environment and in the host. RSV is a reasonably stable virus and only changes, very slightly over time. There's RSV-A and there's RSV-B, and it doesn't change. It's one of those viruses that doesn't change much. Flu, as we know, drifts along, and every year it changes its makeup slightly, which is why we have to have a new formulation of vaccine every year. Flu is also able to combine with other viruses, such as flu viruses in particularly poultry and pigs. As we know, the 2009 pandemic of flu H1N1 was a combination of human flu and swine flu elements to make a brand new flu virus. So we know flu does that. It can change its makeup, which is why its potential to become pandemic is big, because it's able to change itself. And I think we've seen with COVID how it's able to mutate, and we have variants popping up all the time. So it's similar to flu. It's different, but it's the same idea, is that it's able to change its makeup much more effectively than a virus, say, like RSV or measles. So that's why it's also easy to have a measles vaccine, because you're dealing with a virus that changes very little. And so your vaccine works. And the vaccine we developed in the 1960s is still working. Whereas with flu and SARS, we've had to be on our toes a little more and change those vaccines and constantly work to protect it. To have some sort of prevention technology against it. So yes, those questions are all asked. There are modelers who love to do viral interaction modeling. It's really complex. If this many people have it and this number of viruses interact, what would you get? But that's a modeling, and that's so that's kind of taking educated guesses at what it does. So yes, is that a reasonable answer? Is that enough?
Yes, I followed you word by word, and I think I'm getting it. Thanks for that. Before I ask Dr. Shibambu to present, on the Q&A, there's a question from Jabulani, but because it says question for Dr. Moyes, so he says is the projection still May, or do you see that we would have RSV beyond May, considering the relaxations and the fact that we are all back to school and our normal ways of doing things? You can just look at it on the Q&A section there.
The Q&A, I think I'm on the chat. Okay.
Yeah, sorry about
okay,
that.
no, that's okay. So yes, well, yeah, Jabulani, your guess is probably as good as mine. Because we were so certain of what we would see with RSV all the time, and when the pandemic came, it messed up with our real understanding. Well, it just showed how these viruses and the various protection mechanisms, how they can change things. I suspect because it's because this modeling is predicting it to be a very intense season, that it probably will go on. I think what will be interesting is to see what flu does this year. And of course, the perfect storm is we have a peak of COVID, a peak of RSV, and a peak of flu at the same time. I mean, that for clinicians, that probably make them want to run away. But so those are those are all the things that this year will pan out. But I do think it will be a longer season. Especially now when masks are going to go. I mean, they're already, the kids don't have to wear them outside, and I suspect that at a lot of schools they're not being very well enforced anyway. So it could be interesting to see.
Yeah, so two important comments on the chat. One colleague says she has referred a whole lot of babies to the next level of care, suspected pneumonia. And I see there's a colleague from Prudence who says they've observed a massive increase in admissions, but luckily most of the admissions were a little bit mild, but they had a number of cases that were quite severe, actually 2 needing to be intubated. And if you look at the months there, she talks about a 4-month-old and a 7-month-old child who could have been born when we were wearing masks, and then now openly exposed to RSV later. Yeah, I don't know if you have a comment. Otherwise, I want to hear what Dr. was going to say on the clinical side. Yes.
Yeah, so I'll a quick comment. I won't take too much more time, but that Prudence, it's really interesting, and thank you for that comment. And I'll certainly pass it on to my colleagues. I know that at Brahima Musa, they are using high flow nasal oxygen to treat a lot of their kids with RSV. But I mean, I'm not sure whether in your setting you would have that, but that was certainly from Gary Rubinson. That was, his comment was that that's what they were, a lot more children on that. So what you're telling me fits with more or less what we predicted.
Yes, no, thank you very much, Dr. Moyes. I hope you are still around, because maybe at the end we might have more questions, especially from the ones I have written down. I did ask Dr. Shibambu because he's a local pediatrician, and when my son was not okay, he did let me know before I even read the NICD report that he's seeing, a whole lot of viral infections and so on. So, colleagues, we still have some time, so let's then give Dr. Shibambu, he's got just a few slides on the clinical side. So if you see a baby tomorrow, how are they likely to present, and how would you approach such a child? Continue sharing your comments and questions on the chat, but also on the Q&A, and then hopefully we'll have further discussions from there. Thank you, Dr. Shibambu. You may please unmute.
Okay. Thank you very much. Let me first thank you for the opportunity just to come and share with the colleagues in this platform. Yeah, it is the right time to be talking about RSV, because as you have seen when they were talking about epidemiology, we are also in the ground. We are now seeing lots of children, especially the younger one, few months old, presenting to us with this RSV bronchiolitis. So I'm just gonna adding to what you have presented. I won't be talking more of epidemiology, as we already covered. So just to remind colleagues about what is bronchiolitis in the simple terms. Bronchiolitis is a viral-induced lower respiratory tract infections that occur predominantly in children younger than 2 years old. You can still see that in the bit older kids under 5, but it's more common in the younger, the smaller one. They under 1, they can even get more severe form. Those are the likely children that you will need admission in the hospital. And the majority of them, as we said, the patient there, they just had a milder form, which they may not even require any hospital admission, can be managed at home. So just this as a reminder to know what bronchiolitis is all about. What's happened to the bronchiolitis, just you see there's some inflammation in those tiny airway where there's inflammation, and there's some mucus formations which cause some obstruction and air trapping. That's when they will start showing some difficulty in breathing and wheezing due to the airway obstruction. So we are now talking about the RSV as the cause of bronchiolitis. It's the main one. There's all other viruses that also cause the same bronchiolitis, but the most common one is RSV, and we see it causing a bit more severe illness in the very, very small children, especially under 1. There are also others that we've been seeing, like rhinovirus. Rhinovirus is, things have been there, I think, throughout since the last year. I think almost we always have rhinovirus coming in and out. Sometimes they can get, we get combination of these viruses. The rhinoviruses, the adenovirus parainfluenza, we are seeing more of them in children. Recently, we're also seeing a little bit of influenza coming now and then, but even though it's not the dominant one, the dominant one is RSV and the rhinovirus, which is following them. So how do they present to us? Usually when they have RSV, they'll present with some upper respiratory tract symptoms like rhinovirus, rhinorrhea, they get some fever, low-grade fever, cough, and poor feeding, especially the smaller one. It just followed by a day or 2 days later, they will have some tachypnea, hyperinflation, and wheezings. As the inflammation, they get inflammation, and we do the air trapping, they'll start having the wheezing. And just to remind you, this is usually the general self-limiting disease, but it can get more severe, where they'll start showing the grunting, some nasal flaring, and subcostal chest recession, hypoxia, and also showing the sign, the Hoover sign. So when they show that, you can say now they are now in a severe form, which those are the patients who definitely gonna require to be monitored in the hospital so that we to assist the child. And to just also to assist in when grading the severity. You can also grade them to a mild, moderate, and severe. So the severe one, they are those who present to you, and they are not interested to feed, or they don't want to feed, usually because they are mainly blocked, they have nasal congestions, so they are struggling to breathe. So if feeding becomes difficult in those groups, they come to you tachypneic and with some chest recession, nasal flaring and grunting. And we check saturations when present with a saturation of less than 88. Those ones just on the severe form, and they may also be lethargic. All this one will require to be managed as an inpatient, need to be admitted. But the milder form, those who don't really have a severe recession, so who are feeding well with a normal saturation, this one can be managed at home, can be seen in the rooms and be monitored at home. The severe one, you have to be admitted because these children, they are likely to, in that and the hypoxia, they are likely to be dehydrated, but they'll struggle with the feeding. So how do we manage it? There are lots of controversies in terms of the management of bronchiolitis. You know, the main management of bronchiolitis is mainly supportive, because there's no specific treatment, specific drug that is there to treat RSV, bronchiolitis. It's mainly supportive. We have to make sure they are feeding well, so maintain their hydration status. If they are unable to feed, they may need to support them with some fluid management to make sure that they are well hydrated. And so those who have some severe form, they may need a bit of oxygen support, especially those who come with low saturation and those who are hypoxic, depending on the severity. For some, they just need a nasal clearing just to clear the nostrils, and then they'll be fine. Those who are distressed with hypoxia, you can give a supplementary oxygen with the nasal prongs. And only those who are showing some severe form and severe distress, you can now, those one use the high flow for those who have high flow and the CPAP. High flow, I've seen most children with severe form, they usually do well on the high flow. They hardly require to be ventilated, put on the ventilator. Very few of them will require ventilator. They will end up there on the high flow. But majority of patients that we see, they just need a supplemental oxygen. Some they're just fine on room air. They just need just a bit of assistance. So very few require intubation. I only recently had one which require intubation. Was a 6 weeks old with RSV. Had a very severe, struggling, very hypoxic. It's the only one that I remember that we have to intubate and send to ICU due to RSV bronchiolitis. And there are also other form of treatment that are being used, but most studies have shown that those treatments they don't really make much change. They are shown not to reduce the hospital stay or reduce the progression of a disease. So they're usually not routinely recommended. They are being used, but there's some different school of thought on their use, especially like the use of bronchodilator to nebulize them is being used. Unfortunately, most school of thought, they are not recommending, and the use of steroids, the hypertonic saline to nebulize, irrespective of whether it's 3% or 5%, and the use of montelukast and chest physiotherapy. Initial chest physiotherapy was considered to be helpful because it will assist with clearing the flame on the chest. But most literature, they find it is not really making much difference when they do the study looking at that. And the use of antibiotics. The use of antibiotics, you remember the RSV is a virus, so the antibiotics is not gonna make any difference unless that child that we're managing have some secondary bacterial infections. That's when the antibiotics may be indicated. However, we have seen lots of children, they are being put on antibiotics, mainly because maybe we are just a reflex that clinicians have, that we just throw everything, hoping we'll be able to kill the virus. But because the viral, whether you can put any fancy antibiotics, it won't make any difference. The only thing they need is just mainly supportive. I must be honest, I do use some of this form, especially the steroids, the chest physiotherapy. We do use them. We do use some of the kids who will respond, but majority of them, it won't really make a difference whether you have used them or not used them. Maybe the reason why the studies, most studies are showing them they're not really to be used routinely, because they showed no difference in terms of improving the sickness. So there's also which the previous speaker also mentioned when talking about prevention, that and all this prevention is also very much important. He spoke about hand washing and avoiding the contact with people who have cold. Unfortunately, we work with children. We see most parents, we still gonna allow their children to go to the preschool crèche, knowing exactly that they are sick. And when they are at those environments, the kids are kids, they share everything. So that's why we start to see lots of disinfection from those who go to the preschools because of that. And because they share everything, they share utensils, they share cups, they share toys. So that's where they infect each other. So it's our advice, as we talk to our parents, to our patients, we advise the mothers, if their children are sick, they must keep them at home for that period when they are sick. And also about the covering the mouth when you are coughing, and also avoid smoking in public, but that can also influence the increase of these infections. And also about we must remember that also there is no vaccine currently that is meant to prevent RSV infections. There's currently no vaccines. What is happening now, what's happening, there's some RSV monoclonal antibody, which is palivizumab, which we have said, you heard in the previous speaker, is one of the very expensive, and which is in our country like ours, which cannot afford to give that to every patient in the country. Even in private sector also cannot afford to give these patients, to give this palivizumab to every child in private. It can be given to some kids who have some risk factors, especially the premature babies, and those who have bronchopulmonary dysplasia, and those with chronic lung disease, primary immunodeficiencies, cyanotic congenital heart disease with hemodynamic instability. So those one can qualify for palivizumab with some motivation. With the motivation, some medical aids are able to cover the cost for this drug. So it's currently one of the modality which it can assist in preventing the severe form of RSV bronchiolitis. So the issue is the cost and availability. So it's not as accessible, will be accessible by a majority of children in our country. So yeah, that's briefly about the RSV in the clinical. So I don't want to make a very long talk because we have that talk before. Just more of the just stimulate and remind people that RSV is here, and so that we become aware, so that is here, so that we can start with the prevention measures and educating parents before they even come to our hospitals. So I think that's all from me. Thank you for this opportunity.
Great.
Lisiho.
Thank you very much, Doc. This was quite short and to the point, and I see that we still have a few moments to engage further. But can you just clarify for us, Doc, COVID-19, flu, RSV, when a child presents, how does one suspect one versus the other? Are there specific clinical indicators or tips from the history of the patient, or should we reduce this to some mandatory testing for all babies who present with respiratory symptoms? What's your experience, and maybe what do the guidelines say as well? Thanks.
Okay, thanks for that. Unfortunately, most of these viruses don't present in a similar way. They present with those upper respiratory tract infections. Only later they can progress to that. We've spoken earlier on about those RSV, about the rhinovirus, parainfluenza, adenovirus. They present in a similar way. So clinically, it's not easy to differentiate which virus we have. Even the COVID, you can present in a similar way. So it's so difficult to differentiate clinically. The only way to differentiate is by doing those tests, using the biofire to identify which viruses are there. Unfortunately, also with the cost of that biofire test, it's be difficult to do those tests in everyone, especially in public sector. It's going to be quite difficult. In private, yes, we are able to do this test to every child who will have the symptoms, and we will know exactly which germ is there. But generally, if you say you can't differentiate them, their management is usually not that different. It's usually approach is the same. The way there's a bit of different addition to the treatment is in the case of influenza, because we also add the Tamiflu on the picture. But generally, all other these respiratory viruses that are common, they will require almost similar treatment. It's just the only different thing. I think that with the RSV, usually the smaller kids, they can really get more severe and usually can last a bit longer if they are not well managed. So that's the only thing, but generally they present in a similar way.
Great stuff. Thanks, Doc. Before I ask more questions, Renee Chabeleng, I hope you are I know I'm putting you on spot. Are you able to unmute your mask? You made a comment. There's the clinical part around the type of viruses you are seeing and the type of cases, but you also want to motivate why your facility must be considered for a surveillance site. Renee Chabeleng, are you able to just make a few comments? It would be nice to hear your voice. Thanks.
Hi. Thank you, Lisero, and thank you, Dr. Patrick. I know Patrick, he knows me very well. Yeah, my point was like, in our hospital, because we do admit patients from regionals and district hospital, because we are a tertiary hospital. So most of the time we admit them, they're very sick. And we are forced, most of the time we do the multiplex PCR. But most of the time when it comes out, the results will be a mixed picture. So my point is like saying, you can't really clinically tell that is an RSV, bronchiolitis, maybe adeno, human metapneumoviruses and the rest. So also on that to say that it will be nice also people to know that high flow and the CPAP can still work better before even considering like intubation rather. Because most of the time then we admit this patient, they're already sick, they're already having those severe distresses, head bobbing, lethargic and all those. So it comes to be a problem. So people should know that high flow nasal cannula CPAP is still the good modality compared to the endotracheal intubation, because most of the time these patients have got mucus plaque. That's what is causing most of the problems. So I think on that, on Dr. Pat mentioned the non-ventilatory modalities, or those that are not considered, because there were a lot of journals that were done by Prof. Robin Greens or whatever. So I think, but considering because there's a mucus plaque in there, I think doing a bit of chest physio is also, or I've seen most patients, it really helps, and also considering the hypertonic saline nerves, so that at least at the district level or regional level, they can consider that while waiting for help. Most of the patients, they do really improve after giving that. So then the other thing, considering to tell Dr. Joycelyn and say that we really want to be included as part of those hospitals. Because at least at this side, we've got pulmonologists, we've got ICU, we can even collect data. It's easy to collect data and to get to that part of the research.
All right, maybe let me start with, okay, thanks, Doc. You can comment and then maybe Dr. Boyes will make follow-up comments and stuff. Thanks.
Okay, thanks very much, Renelo, for that comment. Yeah, it's very valid. I agree with you. Ventilation should be the last modality if everything fails. Most children, they do very well on the high flow. Even those who are very, very sick, you put them on high flow, within few hours, you can see how much they recover. They recover very quick. So I would recommend that if you have a high flow in your things, use them. They work very, very well. And also with the use of hypertonic saline chest physio. Of course, they work. I use that and it works. So unfortunately, our studies, the one we just talking about, those done by Robin Green with the team, they also don't really recommend the the routine use of them, but they really work well, especially in clearing the phlegm in the chest, because I think that's the main thing, and clearing the nose, they work very well. So if you have those, you can still use.
Okay.
Thank you.
No, thanks. Dr. Moyes, Limpopo was the site, but I'm sure you've got other comments as well.
Yes, I'm excited to hear that. And I think Maseko has my email address, so please pop me an email and we can take up the conversation on including your hospital as a site. I just wanted to say about these multiplex PCR tests for respiratory viruses. We have described in a lot of the stuff we've written co-infections with RSV and rhino, adeno, influenza, the whole list. And so it would not be uncommon to get one or two of those viruses identified. I mean, I think because PCR tests are so sensitive and so specific, so sensitive, you must remember that you're going to identify viruses, and then it's always a discussion on cause, whether that virus is a passenger in the nasal, the nasopharynx where you've taken the sample, or whether it's causing the lower respiratory tract things. But I think from a clinical point of view, you would never really know, whether it's causative or passenger. And like Dr. Shibangu said, is that the clinical management is much the same. So, those PCR tests are really nice to have, but they don't necessarily, they help when they tell you it's a virus. But, I think, giving the cause to one or the other is difficult, unless it's RSV season, and in which case, about 80% of those kids or RSV will be the causative virus. So I think, use them, they do help, but, don't remember that there's this background of being able to pick up small bits of virus, because PCRs just need it, as we know from SARS-CoV-2, they just need a little bit of the viral DNA or RNA. They don't even need a whole live virus for it to be positive. So, you go.
Great stuff. Let me check on Dr. Koza, just to check if your hand is truly up.
Still up.
Okay, great. Yes.
Can I ask?
Yes, you may proceed. Thanks.
Somebody mentioned Tamiflu. We as GPs have a problem because of the cost, one, and the turnaround time. We cannot wait for a PCR. And I wanted to ask if a trial of Tamiflu, when you're not sure which virus it is, when you get a very bad one, is it really cost effective to try a Tamiflu? If caught early enough.
Tamiflu is very influenza specific.
Yes.
So,
yes, but how would you tell on the first visit which virus we're dealing with?
Well, that's the difficulty. I mean, and that's, if it's the middle of the flu season, it's July, and they've got flu-like symptoms, and they've got a lot of risk factors for severe influenza, then your Tamiflu, may well be a good call. But if you're between seasons and they don't have underlying conditions and you can't do a test, I don't know whether there's a place for Tamiflu. I don't know if Dr. Shibambu agrees with me on that.
No, I agree. Tamiflu is for influenza. It's only work for influenza. Those and the other thing it won't work unless we know what we are now in the season for influenza. You can put it like with that happened somewhere around November, December. We had a lot of influenza cases. If you have maybe you have one child to confirm influenza, 3 other children at home with the same thing, you can assume all other one have influenza and just give them even before testing for it, because the tests are really gonna be quite expensive.
Yes.
But yeah, if not out of season, I don't think they need a use for the Tamiflu.
I think
thank you very much.
The challenge, and I think Dr. Koza is okay, but I just want to because I think I understand the challenge, the divide, between those who are able to confirm, because Dr. Shibambu, you are referring to a series of confirmed cases after you do PCRs. But generally, on the other side, we don't do a lot of PCRs for viral infections. Hence, you'll find people treating. And I saw there's a discussion on the chat around antibiotics. Other people are even saying patients who are on antibiotics do better or recover quicker than those who are not. And I think I shared my comment on that to say this is a viral infection, no need for antibiotics. I think that one is very clear. But we should also help the other side where PCR tests are not necessarily the standard, you know, when these babies present. And most likely they'll be treated with some generic treatments. I don't know if you want to comment on how to approach. I think you did say the approach is the same based on how the baby presents clinically, and you can scale up the supportive care. But generally, from what I hear, you don't recommend overzealous use of either antibiotics or antivirals unless indicated and in season. Is that your comment on this?
Yeah, that's my take.
Okay.
If we are out of season, we cannot really use the Tamiflu because it's not gonna do any benefit other than just more of increasing the cost. The same with antibiotic. If we don't really find anything that suggests a bacteria caused by bacteria, there'll be no need for antibiotics, unless maybe in such patient that you present to you also present with the severe tonsillitis. Antibiotics may be indicated there because you may be suspecting there may be some secondary bacterial infection. Other than that, whether you use it or not use it, it don't really gonna make any difference other than increasing the risk of antibiotics resistance. And when that particular child becomes sick to a point where you need antibiotics may not work because we are being overusing antibiotics that particular child, and that child may require the very strong antibiotic which need to be admitted because the basic antibiotics will now be resistant because they're being because of overuse. So if there's nothing suggesting bacterial infection, I would suggest stay away from antibiotics and use those supportive medication just to be for benefit for that particular child. I know sometimes in private practice, it's not easy when the parents come to you, they expect antibiotics. But a little bit of education may help. Giving antibiotics over and over, it may cause damage to the child than helping. Because they want you to give all these sort of antibiotics, but it's not gonna benefit that child by giving them all these causes of antibiotics.
Yeah, no, thanks for that. Maybe on the clinical side, there is a comment by Louisa. Maybe you can look at it in the meantime, Dr. Shibambu. But I want to ask Dr. Moyes, can you comment on RSV infections and the issues of wheezing or asthma or the risk of long-term asthma for babies who had RSV? And then maybe Dr. Patrick, you can add after that comment. And then I think we should be starting to do our closing remarks immediately after that. Thanks.
Yeah, I think that's well documented, and Dr. Shibambu can back me up, but that there are long-term sequelae from RSV infections. And, you know, there's this long-term wheezing or intermittent and persistent wheezing. And then, you know, it often precedes an asthma diagnosis. And Heather Zahn in Cape Town recently did a really nice study where they followed a birth cohort of children, and they actually documented, you know, all their respiratory infections. It's called the Drakenstein study. And they showed quite clearly this long-term association between RSV infection and wheezing, persistent wheeze. So, you know, children wheeze on and off, through their, you know, up until about the age of 5. And then it seems that you know, whether the lungs get more mature, the respiratory system gets more mature, or whatever the mechanism. They seem to outgrow it in inverted commas, but it is well documented.
Great. Thank you for that, Dr. Mayes. Dr. Shibambu, any additions? And maybe after reading that, you realize that the case on the chart, just looking at the treatments, I can tell that this is probably from the private sector and probably from a pediatrician. And I see half the things that are there, the things that are not recommended from your studies. But you may comment on asthma or in the context of RSV, and then we take it from there. Thanks.
Yeah, thank you for that. Remember though, these viruses, they cause some inflammation of the airway. The similar thing that can happen in an asthma patient. So the same viruses, the same like RSV and the rhinovirus, they tend to activate the asthma attacks in some of most of the patients. I have seen few patients who come with asthma attack. When we do those tests, we can find them they have mainly rhinovirus, but then when rhinoviruses, very few come with RSV. But the same virus cause the inflammation, which they can present more like with an asthma attack because of the same virus. Not necessarily the allergen, by the same virus. So probably the same thing happen in the patients that is being asked is asthmatic at RSV. So that RSV can also activate the virus, the asthma attack. So I think that's maybe what's happened in this situation.
No. Thank you for that. That was very enlightening. Maybe going back to, as we close, as you say, your closing remarks, Dr. Moyes, in your last slide, you referred to preparedness. So considering that most hospitals are supposed to be having some level of preparedness for COVID, because yes, things are getting lighter, but the virus is still there. What are the top 2, 3 things that you would consider important as we prepare for the 32% increase in cases or admissions, and particularly for the rather older? They are still young, less than a year, but your 3 month, 6 month old kids. Yeah, thanks.
I always think that, awareness is it's quite a good weapon. And I think that, just being aware that it is RSV season, that these children are likely to have RSV, and just to think a little broader than your normal, it's in the less than 6 months and it looks like this, just to remember that perhaps the older child has also, maybe they have got it. And I think also education of, staff that are doing intake wards or in the casualties. Guys, it's the RSV season. We're seeing a lot of RSV. If you're worried about a child, let's assess them and see if we can, we can work closely to make sure these children, particularly in smaller hospitals, and just get adequate treatment, and so that we don't have we don't have a season that's associated with an increased mortality rate. Because I think, as Dr. Shibambu said, these children do often respond really well to simple treatment like oxygen. And so I think if we're aware, then we can act, be prepared.
Great stuff. Thank you very much, Dr. Moyes. I really appreciate your time. I think the colleagues as well, they really appreciate this particular session. It was quite enlightening, and I think the takeaway really, and I sort of repeated it, is that we are likely to have an increase in the number of cases, but also we should start to not exclude the older infants, 6-month-old, 8-month-old presenting with a wheeze and so on. We should be very aware and be able to provide the right level of care. So thank you for that. Dr. Shibambu, from a clinician's point of view, what are the top 2, 3 take-home points in the clinical care space based on your presentation, and you can just wrap up for us from there. Thank you.
Okay, thank you very much. Just a high level of suspicion is important as we see these patients coming to you, and then manage them with the basic. The simple is the best. Simplicity, basic treatment. Avoid also over treatment, and also to remember that not everything that wheeze is asthma. In smaller children, mostly it's because of the viral infections, that the one we are talking about, they present with wheezing. Because most of the patients that they put on the asthma patient, they don't have asthma. It's only because they just have this viral, and it's possible to have this viral infection now, and next month get rhinovirus, the other months get adenovirus. So most of them, they end up being put on asthma treatment wrongly. Just remember, viral is still the main cause of wheezing in the smaller children. And also, I repeat, avoid overuse of antibiotics. If they are really in severe, you can refer them where they can be managed appropriately, or they can do the test. I can't advise to do tests in outpatient because it's too expensive. Even the medical aid may not pay for those done outpatients, but if the inpatient one, they can easily do those. Otherwise, I think that's all. I think we all have been learning. I also have been learning a lot in the same platform, the comment and discussion. We all learn from that. Thank you, Doc.